I've been reading quite a few articles on parkrun. It's Professor James Hull asked people in the parkrun groups all over the country to carry an iPhone and just record themselves breathing, the sound of their breathing. And then at the end, they've analysed it, and they're picking up, again, vocal cord, EILO, I think we're calling it here, vocal cord disorder, where often people have actually been diagnosed as asthmatic. And they're doing that because of the difference in the sound that people are making when they're starting to struggle, whether it's a sort of asthma-y sound, lower in the lungs, or more of a that you're going to get with the throat.
Did you want me to share when you were just asking? And this is a sneak preview, though.
Oh, yeah, go on.
It's going to come out in the BTS respiratory clinical statement. So this, of course, is just not a diagnostic tool in itself, but within the clinical statement. And apologies, I'm going back. I was just having a little listen whilst you were chatting, but a little look. Just some simple sort of differential diagnosis between the exercise-induced laryngeal obstruction, exercise-induced bronchoconstriction with asthma, and your breathing pattern disorder.
Excellent, perfect.
Yeah. So, but within the statement, it does go into a bit more depth around it. So I do think it's going to be like a nice, very brief overview, to help guide clinicians. And that was the point of it, really, was to help different people kind of work through what could be going on.
I think that's really good. Do you want to just keep that up there a minute?
Yeah.
There's quite a lot on there. We've got 2 minutes before 1:45. If you just take us through that, if you wouldn't mind.
Yeah. So
and then we'll go and have a coffee.
With EILO, so it's often, if it's EILO, you tend to get the symptoms on peak exercise. So you often see it's a very sudden onset, and it's as soon as you stop that exercise, it's a very sudden resolution. And the typical symptoms, now it says breathlessness and wheeze, and it's not, in the text it kind of talks around it, it's not a true wheeze, it's more of a, patients describe it as a wheeze, but it's a stridor. Yeah, exactly that.
Well, nobody would know the word stridor, would they, unless...
Yeah, absolutely. So it's that high-pitched noise, it's associated with your throat tightness, it's often associated with the cough, because you're irritating the upper airway. The upper airway will be drier, you're more likely to bring on the cough receptors, so they respond to that. And inhalers definitely don't work. Whereas your exercise-induced bronchoconstriction, that can happen during exercise, not often at the peak, and the symptoms can start, during exercise, but can actually start, up to 30 minutes after exercise, particularly in adults. In children, we see the symptoms come on a little bit quicker than that, and that's often, patients describe it as problems on the breath in and out, but the true picture is it's on the expiration, it's the wheeze, it's the breathlessness. And again, it's that cough, and the inhalers do help. So your blue inhalers, your short-acting bronchodilators work. Whereas breathing pattern disorder, that can happen so it's a wavy line to try and represent that it happens at any time. It can be at rest, it can be during exercise, after exercise, often made worse with exercise. And people feel like they can't get the breath in. It's that chest tightness rather than throat tightness. And then it talks more in the text about the other sort of symptoms that you get, with hyperventilation and things like that, but also no improvement with inhalers. And with the guideline, we had a discussion because some people report like a placebo effect of inhalers.
Yeah.
But then we took it out because we thought it was a bit confusing. So I can't remember if that's left in the text, but some people go, oh yeah, the inhalers help.
Yeah. No,
but then it comes straight back on. Yeah. So, but yeah, generally that it isn't.
Just with the breathing pattern disorder, you showed the wavy, the erratic wavy line. Do you know what it's like when the same patient is sleeping?
So yeah, it's interesting. Well, this is just from my own experience. So we often use nighttime symptoms as a bit of a guide to what's going on, especially like so if people are saying that they're feeling really breathless and tight, but then all their symptoms disappear overnight, that leads you away from a diagnosis of asthma and more towards a diagnosis of breathing pattern disorder, and definitely away from any EILO sort of symptoms.
Right.
Chronic breathing pattern disorder, you get that in the night and the daytime, and it can wake people up. But we do find that, especially in children, where it might be the first time they've started doing it, they might not be so embedded that overnight that the symptoms do dampen down.
Okay.
So I do see a lot of runners, and I do encourage them to, if they've come to me for, say, a lower limb injury, I do encourage them to rehab their running at the rate that they can nose breathe, which is a great way of pegging how hard they can go. And some of them have read more widely, say Patrick McEwen's Option Advantage, and continued and trained themselves to entirely nose breathe when they run. And they've noticed their performance has improved drastically, a lot. Yeah, so I saw one last week who I hadn't seen for a while, and she said she now entirely nose breathes even when she races. So I thought that was great that they've taken it on board and read more widely and paid a great deal of attention to their breathing when they're running. So I think for those that choose to go that route, it is very trainable.
There's a very good paper on it. I did one of my little videos on it, actually, because it was so interesting. It was triathlon, and they really did a lot of experiments, and really it was showing that people probably need about 4 months of training, when they're running every day, to be able to completely change over to nose breathing. But once they do, they can get the same speeds, and there's sort of potential for possibly going that a little bit further as well. So it was interesting, it was a very good study, really. And it talked about all the problems people have to start with their noses running and all that, and that will just go.
I think as well, what we find is pediatrics are quite different to adults in regards to like EILO and the breathing pattern. And we run so I'm pediatric only, but we go up, right to late teens, and we run a complex breathlessness clinic and have done for a few years now. So those that we suspect have got EILO, so those that are having that stride, that inspiratory harsh noise on exercise, we do a continual laryngoscope whilst they exercise.
You get them into the lab and you put them on a treadmill.
Yeah. So we do it in the physio gym, and we have a look at their breathing pattern. We look at their spirometry. We look at their fraction of exhaled nitric oxide, their correlation.
Do you listen to the sound as well? Is that part of it?
Yeah, we do. I mean, you can, because you've got the camera down, you get a beautiful view of the larynx, so you can see what's happening in the structures. And we surprised ourselves, because I think in adults the prevalence of EILO is a lot greater, but in pediatrics we find that people who were saying that they were tight in their throat, when they had the camera down, they weren't closing, and it was the opposite. It was actually being held wide open. And we thought it was quite interesting. It was almost like a muscle tension, creating the feeling of something being stuck in their throat. But I think adults is very different. I think they see it a lot more commonly. But we did find in our clinics, we find it in the more athletes. But for those who, especially like, I think 95% of our patients had breathing pattern disorder. So I think that has such a key factor in it, and the breathing retraining, the BTACO. There are some, EILO techniques that work specifically if you can see that there's obstruction, but it all just kind of comes together. And on the online course, which I know I'll chat about later, we've introduced a differentiation, a few slides on how you differentiate between your upper airway, breathing pattern disorder, asthma symptoms, anxiety symptoms, because they overlap so much, don't they? And it's challenging for a clinician to work through them, and depending on what access you've got to different tools to identify it's trying to piece different things together from history, from exercise challenges.